It's the top of the hour, so we'll get started. I'm Dia Waguespack in Houston. I'd like to welcome everyone to today's GlomCon seminar. Today, our talk is titled IgA Nephropathy from Childhood to Adulthood, and we welcome our speaker, Dr. Areefa Alladin. Dr. Alladin is a pediatric nephrologist and PhD candidate and researcher at the University of Calgary and the Alberta Children's Hospital. She's completed a clinical research fellowship in glomerulonephritis. Her research focuses on IgA nephropathy and IgA vasculitis in children. She advocates for safe and effective treatment for children, and we're excited to have her educate us today. So with that, I will turn it over to you.
Thanks, Dia. Thanks for the warm introduction. It's my pleasure to be here this morning to speak to you guys. And I heard that you haven't had a lot of pediatric sessions in GlomCon before, so I'm hoping that this is going to be one of many sessions to come.
Yes, we're on the pediatric nephrology trend, so it's great. We're excited to have you. We had one last week, so you will. We're very excited to have you guys because this is so important and maybe a piece that we've been missing in the past. So thank you.
Okay, you're welcome. Okay, so many of you might wonder why I decided to give a talk predominantly to adult nephrologists on IgA nephropathy in children. I have the pleasure of working with a lot of adult nephrologists in Calgary, and my PhD supervisor is an adult nephrologist. We spend a lot of time having constructive discussions and argument about IgA nephropathy management in children versus adults. Is it the same? Is it different? And I realized that we think differently. We might see the cases being similar, but the way that we approach cases between children and adult is actually quite different. This things that we use for decision making as well varies between pediatric and adult nephrology practices. What I also realize is that we operate in silos. Like the pediatric nephrology service is separate, we're in a different institution, and then the adult nephrology service is separate, and we often don't communicate effectively. And this is at a disadvantage to our patients and families. And I think we need to start working together more effectively to improve the outcomes of children and adults with kidney diseases, especially glomerular diseases. So with that, I'll take you through the unique features of childhood IgA nephropathy. What are the current treatments? What are the gaps in care? And what we should think about when we transition patients with IgA nephropathy. Throughout the many discussions that I've had with my adult nephrology colleagues and friends, we ended up writing a paper looking at the differences in IgA nephropathy between children and adults, and this is a narrative review. We still haven't answered the questions, but at least there are a lot more insights into how different this disease is and what we should be thinking about when we're designing trials and clinical pathways. So I will look at the differences based on presentations, risk factors, biopsies, outcomes, and immune system. I'll walk you through the presentations based on a few case studies. And these are actual cases from a cohort that I have looked at in my PhD work. The pictures are not the same and the names have been anonymized for privacy and protection. The first patient is a 15-year-old boy whose name is Chung. He presented with gross hematuria after a cold 6 months prior. After that, he continued with recurrent gross hematuria. And he also had proteinuria. What caused him to present to nephrology services was his recurrent nosebleeds that happened 1 month previously. On referral, he had no hypertension, and there was no history of IgA vasculitis that we could have elicited. His GFR was about 70, and he had nephrotic range proteinuria with a urine protein to creatinine ratio of 230 milligrams per millimole. Our second patient is a 12-year-old girl. She presented with purpuric lesions for about 2 weeks, and she had microscopic hematuria with proteinuria. She was treated in the community for a urinary tract infection. The family was not satisfied with how she was progressing, and they didn't think this was a UTI, so they returned to the emergency at the Children's Hospital. At that time, she was quite hypertensive. Her blood pressures was in the 160s over 100. And she had a history of IgA vasculitis, the classic purpuric rash. Her GFR was around 97 and she had moderate proteinuria. Our third patient is an 11-year-old boy who was followed by community pediatrics for ADHD and intermittent constipation. He reported incidental tea-colored urine. On further examination, they found that he was hypertensive and he had nephrotic syndrome. They called pediatric nephrology services because his blood pressures were quite high. When we saw him, he was admitted at the same time. His creatinine was quite elevated with a GFR of about 55. He had significant proteinuria with a urine protein to creatinine ratio of about 600. And he had blood in the urine as well. On further examination and history taking, we found out that he had a history of IgA vasculitis about 15 months prior to all this episode. So what you can see there is that children present differently, and we know that IgA nephropathy is a heterogeneous disease. It's different between adults and children, but even within the pediatric population, one kid can be quite different from another. The median age at presentation for children is about 10 to 12 years old, and children will get a biopsy within the first few months of presentation. Males are more affected than females in the pediatric population, and that's in North America. And we know that children may have more family history of a kidney disease compared with adults. Again, this is based on very limited data because we don't have a lot of data on pediatric IgA nephropathy in terms of demographics. GFR is usually higher in the pediatric population compared with adults at presentation. And this may be because they present sooner because they have symptoms such as gross hematuria that may declare itself sooner. They tend to have more proteinuria as well and more nephrotic syndrome compared with adults. Up to 36% of children may present with nephrotic syndrome as compared with only up to 10% of adults. Hypertension is more common in adults compared with children. So the main distinguishing clinical presentation between pediatric and adults that's obvious is the gross hematuria that nearly 65% of children will have, as opposed to up to 20% of adults. And this is one of those symptoms that help us to detect kids with IgA nephropathy sooner. In addition to those features, children tend to present when they have an infection, and an infectious trigger may lead to an overt presentation or a relapse of IgA nephropathy. Sometimes infections can increase the production of abnormal IgA molecules, which deposit in the kidney and can lead to overt activation of the multi-hit hypothesis. In addition to that, the M proteins in Streptococcus, for example, can be deposited directly into the glomeruli and lead to activation of complement and other inflammatory markers, leading to mesangial proliferation. And infections can increase your B cell production in the Peyer's patches. And we know that whole gut-kidney talk as well. Infections could also lead to activation of that pathway and an overt presentation. So children tend to have more infections. Those who are susceptible will have an overt presentation of their disease or a relapse. Some children also have genetic predisposition. For IgA nephropathy to present at younger ages much sooner and much more aggressively, there are very few studies that looked into the genetic risk factors for children and adults. Up to 22 risk alleles have been identified. Of those that cause early presentation in children will be a concurrent mutation in collagen 4 or in the risk alleles for gut mucosal integrity. So if you have a leaky gut, then bacteria and viruses are more likely to enter the gut mucosa, triggering the Peyer's production of abnormal IgA and an overt presentation. These kids will present much sooner, sometimes some literature says around 8 to 10 years of age, and they may have more aggressive disease compared to those who do not have a genetic predisposition. Now, what happened to these three kids? The first kid, Chung, got no treatment. He was scheduled for a biopsy, which he got 5 weeks later. Rebecca was started on perindopril and amlodipine for her blood pressure and proteinuria. She was biopsied 3 months later, and that's because she had a GFR of around 97 to 100 and moderate proteinuria, so she was more on a conservative management and a watch and wait. Flynn had severe disease at presentation, so he was admitted and he got a kidney biopsy at the time of admission. When you look at their biopsy report, the biopsy reports for patient 1 and 2 are actually the same in terms of their MES scores. They both had mesangial hypercellularity with endocapillary hypercellularity. They also had the S1 lesions, no T lesions, and C1 lesions. No global sclerosis and minimal interstitial fibrosis and tubular atrophy. They both had some foot process effacement and some signs of complement activation. When you look at the third patient, he had 50% interstitial fibrosis. He also had diffuse inflammation. So there was a mixture of activity and chronicity on his biopsy. He also had C3 activation with 2+ staining as opposed to the first two patients who only had 1+ intensity. And he had extensive foot process effacement. If you can recall, his protein to creatinine ratio was 600, which is about 6 grams per day. In children, we know that the biopsy shows more inflammatory lesion as opposed to adults who may have more chronic lesions. And this may be based on just timing of diagnosis because kids are detected sooner and they have a shorter time to biopsy compared with adults. The other interesting thing that we found comparing children with adults is that children would have more activation of their complement pathway with increased deposition of C4d, mannose binding lectin, and terminal complement. They may also have concurrent podocytopathies, and we know that there is a component of IgA nephropathy, minimal change disease. And they may also have more COL4A1 variants and mutations. Immune-wise, we know that complement dysregulation may be a bit higher in children, and those who have more complement dysregulation tend to have worse disease. It's associated with poorer prognosis. And compared with adults, children have lower levels of galactose-deficient IgA, but it's higher than their healthy controls. Now, how do we treat children with IgA nephropathy? I know that there is the talk now about IgA nephropathy meeting. It's exploding. The landscape is changing. There are lots of access to medications and new drugs and all these trials, but we still don't have access in children. Children are still excluded from the trials. And so we continue to do what we've been doing for many, many years. We treat with POSI protocol. So these kids got POSI protocol. The first case, Chung was treated with 9 pulses of methylprednisolone at 15 milligrams per kilogram, and then 6 months of prednisolone every other day at 0.5 milligrams per kilogram. And then he was weaned over 3 months. So he had a total of 9 months of steroids. He was started on perindopril at presentation as well. After completion of the 9 months of therapy, he did not improve in terms of proteinuria. So he was transitioned over to fish oil and no improvement again. 2 years later, continued with nephrotic range proteinuria and then was started on hydroxychloroquine in some attempt to reduce proteinuria. Rebecca, on the other hand, got conservative management. She never received any immunosuppression. She remained on perindopril and she went into remission. Her GFR had improved by about 6, and she continues to be in remission and doing well. Flynn, also treated with POSI protocol. He had active inflammation and chronicity on his first biopsy. POSI protocol was started within 24 hours of presentation with a similar protocol as patient 1. After completion of POSI, he got mycophenolate because he continued with nephrotic range proteinuria, and fosinapril was also started on admission. What we've realized is that there's a lot of practice variation in pediatric nephrology, and that is because we don't have a pediatric specific guideline. We recently have one that was published in September of last year from IPNA. Prior to that, there were no guidelines. So we followed the adult nephrology guidelines for the most part, but also a lot of practice variation because we didn't have clinical trials to get evidence from. We know that supportive therapy is suboptimal in the pediatric population. We don't maximize RAS inhibition and we don't start them on time. Comparing children to adults, 49 to 75% of children would be started on RAS inhibitors as opposed to nearly 95% of adults. We would use more immunosuppressive therapy. We use them sooner, we use them for longer periods, and we use them a lot. Most of the children with IgA nephropathy will be treated with steroids as opposed to adults where only about half of them will get steroids. We also use second-line immunosuppressive therapies in an attempt to continue to suppress inflammation and avoid toxicity from steroids. What this has revealed to us is one, practice variation is high, but two, we don't have access to anything else to use. We don't have evidence to guide us in terms of when we start and when we stop these steroids and what is the optimal dose. And we have to balance risk and benefits. The other thing with pediatrics is that we have to think about patients and families. And when you hear that the child has a diagnosis of a kidney disease that can lead to kidney failure, you tend to want to do everything to stop or slow that progression. And the parents will also ask this of you. And then we have that guilt if they progress and we didn't do everything. We tend to blame ourselves a lot for that. And I think that's a practice that is hard to change. So we will treat and we will treat with everything. And if they progress, we're like, at least we tried. Now, in terms of kidney outcomes in children, it was long said that IgA nephropathy is benign in the pediatric population. We know that's not true. IgA nephropathy is not a benign disease. Data from the RADAR study has shown that those who present with severe disease will have an annual decline of about 4 mils per minute per 1.73 meters square in GFR, which is quite similar to adults. And if you follow children from pediatrics way up to adulthood, 40% of them will have progressive kidney disease or kidney failure over their lifetime. Children will also have higher remission rates compared with adults. So that is a bit comforting. And sometimes we watch and wait to see those who will go into remission. The other thing to note is that those who had an IgA nephropathy presentation during childhood have a higher risk of post-transplant recurrence. And age was an independent risk factor of post-transplant recurrence prediction. The younger the age, the higher the risk of recurrence. Of course, this data is riddled with selection bias and lead time bias. We only biopsy patients who have moderate to severe disease and those who are likely to be treated. And so these cohorts that are all reported in the literature are actually more severe disease. The mild cases who never got a biopsy are excluded from this. And so our incidence of kidney failure might actually be less. When we compare pediatric to adult data as well, there is lead time bias. So those who got diagnosed sooner might appear to do better, but that is just because of the timing of diagnosis. So we have to take this data with a pinch of salt. All that to say is that IgA nephropathy is not benign in children or adulthood, and we need to think about progression of kidney disease when we're treating children. Okay. So I'll walk you through the outcomes and the progression of the kidney diseases in these 3 patients. Chung continued with nephrotic range proteinuria. So remember, he was treated with PASI protocol. Then he was on perindopril fish oil and hydroxychloroquine. After 5 years, he was around 19 years at the time. His GFR also continued to slowly decline. He got a second biopsy in preparation for a transition. And this second biopsy showed global sclerosis. As far as biopsy, he had no global sclerosis. He had moderate interstitial fibrosis and tubular atrophy, which was more than 25%. So he had a T lesion of 0. In biopsy number 2, his T lesion was 1. His foot process replacement resolved, and he continued to have some staining of C3. His GFR continued to decline, and after the second biopsy, he was started on mycophenolate, and hydroxychloroquine was stopped. He was transitioned over to adult nephrology, continued with nephrotic range proteinuria. He was still on treatment with perindopril and mycophenolate. Adult nephrology wanted to know if this was progressive disease or something else going on. So he got a third biopsy. And that third biopsy showed progression of his global sclerosis and IFTA. And he continued to remain on mycophenolate with progressive GFR decline of about 7.7 per year, and nephrotic range proteinuria that never got better. So he was treated with steroids, hydroxychloroquine, and mycophenolate. An SGLT2 inhibitor was added, and he was on max dose perindopril as well. And he continues with progressive CKD. After 9 years, his GFR now is around 30. Rebecca, who never got any immunosuppressive therapy, went into remission and is being prepared for a transition to community practice for a follow-up. Flynn, who came in with a GFR of around 55 and got POSI protocol on admission, continued with progressive GFR decline. Nephrotic range proteinuria never increased. He was always on immunosuppressive therapy. After he completed about 2 years of therapy, his GFR continued to decline, and he ended up with kidney failure about 2.5 years after diagnosis. He got a second biopsy, which showed worsening of his kidney disease, despite being on MMF at the time of biopsy again. So he was treated with POSI protocol, switched to MMF, stayed on lisinopril, ended up with kidney failure on dialysis 2.5 years later. He's now transplanted. So those are the current therapies that we use in children, and nothing much has changed. We don't have access to anything differently. And we continue to use these immunosuppressive therapy. Whether they work or not, or they slow the disease, is still much for debate. But what we do know is that these medications are associated with a lot of adverse drug events, and we need better options and we need safer treatment. Chung, who had POSI protocol, and Flynn as well, had a cumulative steroid dose of about 250 milligram per kilogram during their treatment. They both had excessive weight gain. Within 6 months, they gained about 7 to 10 kilograms. Chung had acne in addition to his weight gain, while Flynn had hypertension that was worsened, requiring hydralazine treatment. He also developed hyperglycemia and a cataract, and he was baseline ADHD, which was aggravated by steroid treatment. So we know that steroids is not benign. And when we give steroids to these children, we need to think about the long-term consequences. Now, Flynn got transplanted, and after transplant, he was also given low-dose steroids, which worsened some of these events, and he ended up with over-diabetes. In the cohort in Calgary that I looked at for my PhD work, there were about 68% of patients had steroid-induced adverse events, with an average of 2.6 events per person. The most common adverse drug event was weight gain, followed by skin toxicity. Now, imagine we're giving steroids to an average age of about 12 to 14 years, and these children are going through puberty at the same time. They're having a lot of peer pressures and having to deal with body images and mood disorders as well. And then you give them steroids, they gain weight, they get acne, they get stretch marks, their skin don't look well, they get these big moon faces, they become hypertensive, they have impaired glucose tolerance, etc. It is just a recipe for disaster, but we have no other options at this point in time. And it also makes the children lose trust in the health system when they develop these adverse events. They don't want to take their medications, and they're scarred from taking future medications prescribed by nephrologists. So we looked at the unique features of childhood IgA nephropathy and the current treatment. I'm going to go through the gaps in care and transition. In pediatric services, in addition to thinking about the clinical aspect of a patient care, we do a lot of social work, and we do a lot of counseling and patient support and family support. With our teenagers, which is the peak age of IgA nephropathy, we have to think about puberty and how that affects our kids. We need to think about school, the peer pressure and peer influences that they go through, their body images, their relationships. They're not busy focusing on their kidney disease. They have all of these things that are happening to them at the same time that we're trying to treat them and monitor their diseases. Then sometimes they have to deal with the adverse events of steroids. Some of them do progress and end up on dialysis, and some of them require transplants during childhood. All of these events can be quite stressful on children and families, and coping with this requires a lot of support from nephrology services. When these kids turn 18, we have to discharge them from our services. It's time that we say bye and we transition them over to adult services. This can be different for children. It's unique and it depends on where they're at. But what we know is that children with chronic diseases, especially chronic kidney disease, are not mentally mature at 18 as their chronological age, and they do lag behind. And so an 18-year-old may behave like a 14 or a 15-year-old. In addition, they're accustomed to having parents and caregivers help them manage their medications, their decisions, their appointments. We call them frequently. If they miss an appointment, we'll go back and say, hey, can you come in tomorrow? We'll reschedule them. And when we transition them over, if they miss an appointment, they get another 3 months wait. They don't get that close follow-up. A lot of this is due to the lack of access to resources, the busy times with adult nephrology compared to pediatric nephrology, and the type of services. We have more access to a multidisciplinary team who may have more time and training in following teenagers who may not be able to manage their disease themselves. What we do know is that when they turn 18, they don't automatically become an adult. Although we treat them like that in the system and we transition them, they still behave like children, and sometimes we need to accept that and we need to cater for it. In our cohort in Calgary, when we transitioned the patients, nearly 20% of them were lost at the time of transition. So between that age of 17 to 19, when we transitioned them to adult nephrology, some of them never made it over to adult nephrology. Some of them were seen once and then they got lost in that they didn't show up for their second or their third appointment and they were discharged. And some of them just moved or went off to school or college and just lost contact with the system. Some patients get discharged if they're in remission or if they have mild disease. That's due to the overwhelming nature of adult nephrology, and we think that they can be followed by internal medicine or their family doctor with annual urines. And sometimes that doesn't happen and they come back in with severe kidney disease or a crash start on dialysis. This here is quite important because if we don't have a successful transition from pediatric to adult nephrology services and we lose these children, we lose that ability to stop or slow the progression of kidney disease, to offer their support, and then they come back and crash start. It's a recipe for disaster, and we're setting them up for failure if we don't do a good transition process. We know at that time, children who become 18, they're busy adulting. They're now an adult. They have other things to think about. They move, they go to school and university. They're caught up with jobs and making money. They have student debts to repay. They want to get into relationships. They're thinking about fun and travel and independence and all of that. While this is happening, in the background, their kidneys either going through a mild disease or they're in remission, which we hope for. But some of them will have progressive kidney disease, which might be silent and they ignore it, and they may end up with kidney failure. And we know this is a lot of stories of the young adults who come into adult nephrology services. They talk about coming in and feeling sick and then having to start dialysis within a few months of this presentation. So children don't understand consequences of decision. Teenagers just live in the moment. No matter how much we tell them about their future, we can't get them to accept that. And so they'll make decisions that are risky, that will that will put their kidneys at risk and that will put their health at risk. And we need to be able to have a system that helps to pull them back in and guide them so that when they do finally realize the consequences, they would not have caused a lot of damage. The other thing to think about is that when we have a child with childhood IgA nephropathy, we use pediatric guidelines. We now have the International Pediatric Nephrology Association guideline for IgA nephropathy in children, and that's applicable to less than 18 years of age. When you have an adult with adult onset IgA nephropathy, you tend to use the KDIGO guideline. Now, what happens when you have an adult who had a childhood onset IgA nephropathy? After 18 years of age, they get transitioned to adult services and then they are put on the KDIGO adult guideline. But what if this is not the right thing to do? What if these children with childhood onset IgA nephropathy is indeed different from adults with adult onset IgA nephropathy? If their disease mechanism is different, the treatment that they get exposed to changes them, their experience changes them. Shouldn't we cater for a unique pathway that transition these patients and not put them onto an adult pathway? The other thing we need to think about is that we tell children who are 16 or 17 that you can't have this medication because it's not tested and approved for under 18 years or for children. And then the day they turn 18, they automatically have access to all the medications that were restricted to them before. So when we make guidelines, we have to think about those who have childhood onset disease when they transition and cater for those unique features that we should think about. And we also have to think about access and restrictions. One day they don't have access and the next day they turn 18 and they have access. We're sending mixed messages as healthcare professionals. The important thing to note is that a child will only spend about 4 years with pediatric nephrology services. And for the rest of their life, with IgA nephropathy, they will be with adult nephrology services. It means that adult nephrologists will play a more important role in childhood onset disease and therefore should be part of the discussion from the beginning, should really understand the pediatric aspect of this disease and should help us to get evidence to be included in clinical trials. And we should have a better system of working together to improve the childhood onset disease management, the transition period, and then to understand how their disease progressed naturally during adulthood. So I looked at the presentation, how this is different between children and adults. And we know that children will have more gross hematuria, more nephrotic syndrome at presentation, while adults may tend to have a more silent disease. IgA nephropathy may be triggered by more infections in the pediatric population, and this may be due to either strep having the M proteins that cause molecular mimicry, or it activates increased production of abnormal galactose-deficient IgA. We know that in the biopsy findings in children is different from adults, and children may have more inflammatory lesions as compared to adults, and they may have more signs of complement dysregulation, or some of this is due to early diagnosis and lead time bias. We know that children may have increased risk alleles for COL4A mutations and for mucosal integrity, and they may have more complement activation. Children compared with adults may have better outcomes. They have more clinical remission rates for sure. Nearly 1 in 2 kids might go into remission, but they also have progressive kidney disease and kidney failure, and it is not a benign disease. So when we talk about childhood IgA nephropathy, it is different from adult IgA nephropathy. It is unique, and we need to remember that. Children should be included in clinical trials because the only how we're going to change this disease is by having data on children based on their unique features. If we include kids in clinical trials, we might be able to develop targeted therapies that could stop or slow the progression of kidney disease. And we need to get a unique pathway for children who transition over to adulthood. The other thing to think about for the trial is that if you don't have children in the adult trials, what you can do is when you have adults who have childhood onset disease, you can do subgroup analysis to understand how those patients respond to therapies. And that could help us to get data that we can infer onto the pediatric populations when trials are not able to include children because of all the regulatory issues that they face. So in summary, I think we need to continue these discussions between pediatric and adult nephrology services, not just for IgA nephropathy, but for all the glomerular disease. We need to break the silos. We need to meet more. We need to communicate better. And we need to be more inclusive, and we need to be more tolerable of each other. We need to break these silos for the betterment of the kidney disease world and for the children, adolescents, adults, and their families. Thank you, and I'm happy to take any questions or have further discussion on any of this.
Thank you, Dr. Alladin. It was an excellent presentation and such important and relevant information. So we will open up for questions. If you have questions, you can put them in the chat, or also please feel free to raise your hand and we'll directly ask. As we're waiting for some questions, I have a couple questions and comments of my own, but I was fortunate to, in my training, have a required 2-week pediatric nephrology rotation, which, as you eloquently presented, is eye-opening to the difference in how a pediatric patient is managed with dipsticks and that. And it really has helped in my adult practice, especially taking care of GNs and for this audience, right, of glomerular diseases where often they were sick kids. And it's such a drastic change. So making sure those expectations are clear at the beginning of how it's going to be different in the adult practice, but also understanding the support they had before, and not just treating them like the adult patient who's, you know, later older of age and used to the kind of healthcare system that way. So yes, that's something, a message I think, you know, as you know very, very well, and I've seen a glimpse of, and then also had some pediatric nephrology. We've had MedPeds trainees come through our program too, to kind of keep that so important. One question that I had, and then there's some questions in the chat, is you know, the cases you presented, I know from an adult perspective, the IgA vasculitis kind of doesn't fit into any of the guidelines. And usually, and even from own anecdotal and the patients, I have several HSP patients who presented in adulthood, just treating the skin lesions and the steroids they get usually kind of fixes often the what we see in the urine. And sometimes they don't end up even getting a biopsy because the kidney functions okay. And it seems like the treatment approach from the ped side is very similar for both. Is that correct?
Yeah, so I know that the new IPTA guidelines suggest a slightly different treatment pathway, but all in all is if you have IgA vasculitis with nephritis, the treatment is steroids, and it's quite similar to the steroids we would give in primary IgA nephropathy. In clinical practice, sometimes it's hard to get that evidence of a vasculitis, like that third patient that I presented. Until we combed the history really well, we didn't know that he had vasculitis. So he presented and was assumed to be a primary IgA nephropathy patient. So in reality, we treat them the same. They go through the same pathway, we manage them the same way, etc. And some of them do have kidney failure, like half of the IgA vasculitis in my cohort. Again, it's selection bias because we only have the worst disease in the cohort who got biopsied. But half of those patients ended up with kidney failure.
Okay. Okay, thank you. And then there was a question, if you can go over again the length of steroids is in that protocol that you're treating usually for patients with IgA.
Well, that was anecdotal in terms of
Okay.
we use steroids based on POSI protocol historically. The new guidelines that came out last year, the new IPNA guideline recommends a total of 4 to 6 months of steroids. We were doing 6 months and then weaning over 1 to 3 months. So the newer protocol is using less steroids for shorter periods. And we're hoping if we get access to budesonide, it will be less systemic steroid exposure as well.
Yes, and I think along the lines of one of the comments too, the perspective can an effect on the healthcare system. I think that's so true. You almost You almost hope the patient presents at this time a little bit later as they're closer to adulthood, or at least that transition, so they have
Yeah,
access to these medicines that the nephrology community has been so excited about, not realizing that there's, these older teens who could
can't
probably
have them.
benefit.
Yeah.
Yes.
Yeah. And even if we try to use it off-label, the insurance companies wouldn't fund it because it's not approved, and say they use that to say, well, it's not approved for this condition, we wouldn't give it to you.
And then there's a question about using a MMF, um, and any comments on the effectiveness, knowing that, perhaps maybe in the Chinese population from what we know, and just your pediatric use of that.
We have used MMF and azathioprine cycle. Every other second line immunosuppression therapy has been used in this population. And this is because we think it's a more inflammatory disease in the pediatric population. Like that's always been the narrative. It's more inflammatory, so you need to use an anti-inflammatory drug. But when you look at the data, we haven't seen any real benefit of these second line therapies. Like these two of these kids that I presented, they were on MMF. They got a second biopsy, they still had inflammation. So our practice, at least in my center, has changed. They're no longer using MMF because we think it might just show efficacy in the Chinese population or in the Asian population as well. But we have been doing that. The new IPNA guideline also recommends, if we're using second line, to use MMF, ACE, or cyclosporin. We're actually adopting that guideline into local context so that we could use some of this newer evidence, and hoping to get some access to budesonide, which might change the game for us.
Thank you. And can you comment on treatment approach if they recur in transplant as pediatric patients?
If they do recur in transplant, the guideline says to treat them as a primary disease. So you go through the same treatment pathway as if it is a new diagnosis. There is nothing new coming down the pipeline for post-transplant recurrence. So it's steroids again.
And then your comment on it being a potentially more inflammatory disease, you brought up the complement and things. So where do you find the new complement drugs potentially fitting in to really change potentially the course of these younger patients with IgA?
I think as I stare at the data more and more in the pediatric world, it seems as though those that have worse disease outcomes may have more complement dysregulation. And we're hoping, like, we've had a lot of focus group as part of my work as well with pediatric nephrologists, and people are saying, well, now if we see these severe disease, you're seeing an RPGN like picture with a lot of complement activity. Maybe I go straight for a complement inhibitor rather than trying steroids. The problem is we don't have any guidelines on when to start and when to stop, and if they do respond, how long to continue. Even in the adult world, we still don't have those guidelines. So if we started, what do we do afterwards? It is still it's going to be off label, and if you try it, we still don't know how we're going to monitor it. Are we going to do repeat biopsies to see that it works? We don't know. We don't have the answers as yet. And we're hoping they're going to start clinical trials maybe in the adolescents soon, including them in some of those complement trials, and we'll have some data.
All right, thank you. And then a question about genetic testing, and is that helpful as far as the potential either complement genes, or you mentioned the collagen abnormalities?
If we see that they're quite young and their presentation is not the typical IgA nephropathy presentation, for the collagen genes, you'll see some signs on biopsy that there might be mutations because of the thinning of the basement membrane, etc. So a pathologist might recommend that we do genetic testing on those. Some of them with atypical presentations, we do send for genetic testing. But in terms of IgA nephropathy for genetic testing, there is no guideline on doing that as yet because they haven't identified a single gene that is responsible. So no, we don't test for IgA nephropathy. But if we're ruling out other glomerular diseases, or we're thinking there might be more than one disease and it's just an incidental IgA deposit, we would send for a GN panel or other glomerular disease genetic testing.
And then I really liked what you said about the idea of looking retrospectively at patients who are maybe younger adults or adults in trials who may have been treated or diagnosed as children to try to gather some more data that could help your practice. Um, the, Along those lines of that question, one of the things that we see sometimes in the adult world is the patient who may be on the younger end of adulthood but presents with hematuria, normal kidney function, and then we are more likely, I think, to biopsy potentially, and I'd like your thoughts on that. But then they have really IgA deposition but nothing else. Their MES score is essentially zero, and then we're kind of in this, what do we do now with all these new potential drugs? But knowing, and Jonathan Barrett's data of the progression, like you said, and so now, what are you seeing in, like, do you have any or screening, or you see some of these patients who presented as children with more of a mild disease, and kind of what are your thoughts for their follow-up and then even transition of care, knowing that they're going to probably progress even though it's slow, but by the time they're, a younger adult in their 40s as opposed to maybe 50s or 60s with end-stage kidney disease if nothing's done.
So that is an interesting question that we keep looking back at is the mild disease. And the mild diseases, they do go into remission. Like if you present mild and you remain mild and you never had significant proteinuria, a lot of the kids, even within the last few months, we've had maybe about 5 cases that came out. And again, practice variation. Some nephrologists chose to watch and wait. And they got better, and they might go into remission and stay in remission. So there are a group of mild patients who we can watch and wait. We can optimize their RAS blockers, their diet, their exercise, and blood pressure control. And if they have no MES, like a MES score of zero, they might still do better. Even the one girl that I presented that case, retrospectively, when I presented her to our group who did treat her, they said, okay, when I look back at the biopsy, knowing what I know now, I would have given her steroids. But she didn't get steroids and she's in remission. But because they saw, oh, she had crescents and she had M1 and E1 lesions, they would have all treated her with steroids. But at that time, when she got biopsied, Stop IgAN trial had come out and said, well, there was no difference. And so the nephrologist at that time chose to not treat her with steroids and she went into remission. So some of them with mild disease do go into remission. Again, with John Barrett's data, radar data is a biopsy data. And so we only have the severe diseases there. Like their average EFR was 60, I think, to get into that biopsy database. So they do have the worst disease, and that database is biased because the outcomes would be worse. We're missing maybe half of patients who never got a biopsy. They are not part of any of this story. So we're overestimating kidney disease outcomes in these patients.
Thank you. And then there was a comment about the praising your presentation, but commenting on the collaboration between pediatric nephrologists and pediatric psychiatrists and what could be done differently, what's done well, and your thoughts on that.
Okay, so I'll tell you a story. I'm at Spark right now. I don't know if you guys know the IgA Nephropathy Foundation. They have an annual patient conference called Spark. So I was here yesterday and I gave a talk similar about transition and the gaps in care. And there was a pediatric psychiatrist in the audience who was diagnosed with IgA nephropathy. And so we had this long conversation about the differences between the the psychosocial needs of children versus adults and what needs to happen in the pediatric world and what does not actually happen. So in our clinic, for sure, we have a multidisciplinary approach. We have access to a pediatric psychologist, a psychiatrist, and a social worker. And so when patients need those, we try to get their referrals sooner. We had stories where kids are around 16 years to 18 years of age and they need psychosocial support. And because they're at that transition period, they weren't allowed to access the pediatrics support. They needed to go over to the adult nephrology. One of our kids ended up being admitted onto the adult psychiatry ward. And she was 17 at the time, and she said that was the worst medical experience she's ever had. She's lost trust in the system. She didn't know, it's like she just broke all trust after that because a lot of the patients she was placed among for 2 weeks were patients who were going through drug withdrawals, like multiple drug withdrawals, and that was not her problem. She had a transplant. She was dealing with the psychosocial aspects of that, being on steroids, being on multiple immunosuppressive therapy, and dealing with a rapidly progressive GN. But when we do that and we put patients into a system that they don't fit well into, we break their trust and we lose that ability to help them. And it's hard to gain that back. So I think we really need to be careful of the type of services that we offer them and being holistic in our approach to children and to teenagers and young adults. Because even if we have the best of drugs out there and the cures, if they don't take the medication and if they don't follow the rules, the diet, the exercise, whatever we recommend, they don't follow because they're not in that mental health space to do it, we're going to lose them.
Yes, and I think that is something we could all make sure we're doing better or being at least being mindful of, right? Because I think it's as we get older, I know you realize things that are difficult to do and can't imagine doing them at such a young age when you didn't have to worry about those types of things.
Yeah.
And one of the things I always try to stress for medical students is, as difficult as you may think a patient may be, you have not experienced what they've experienced. And they've been there most of their life, right? And so it's so important to advocate for them that they get the assistance they need to be able to take care of their disease, but their well-being as well.
Very much so.
Well, thank you. Let's see. Just there's some questions about rebiopsying. And what would your thresholds be in the pediatric patients for rebiopsying patients, and do you do it?
So I've had this discussion a lot with pathologists and adult nephrologists, and I know the adult nephrologists, quote unquote, almost never rebiopsy unless something really drastic happens. We have a lower threshold for rebiopsy in children, and a lot of our patients actually get a second biopsy if we notice that they have progressive disease. And we want to know, okay, is this a time to give them a second set of steroids, knowing how much side effects they can experience from it? And now the talk about rebiopsy is if you're going to put them on a newer drug or enter a clinical trial for one of these complement inhibitors, etc., you want to know if that drug works. And if you can't measure complement in the blood to first of all see that it's effective, then the only thing is to look at the staining on the biopsy because we have no biomarkers. So I think until we can identify biomarkers to predict treatment and outcomes, having a second biopsy might be a better way to go, at least in the pediatric population, because we have to balance risk and benefits of starting any of these medications.
And I do think we're moving quite a bit more towards at least in this the GlomCon audience for sure of rebiopsying patients in the adult world too, as it's shown to be safer and safer, and hopefully, like you said, with new testing and even disease markers and potential staining, as we're hopeful in the future, will be able to guide us better to more individualize our care.
I agree.
Well, very good. Well,
I think
oh, go ahead, go ahead.
no, I looked at yeah, there's a rebiopsy question and transplanting kidney from an individual with IgAN to someone without. Oh, somebody asked a question about transplanting a kidney from a patient with IgAN to someone without IgAN. We tend to not transplant any patient with take a kidney from anyone with a kidney disease that has some risk of progression because they might need that kidney later. I'm not sure about the risk of having IgAN in the recipient, if that's what the question is about. But we know that when the biopsies that are done at the time of transplant do show incidental deposits of IgA deposits, and that has not led to full-blown disease if they don't have the steps in the multi-hit hypothesis to lead to that. But we wouldn't want to take a kidney from anyone with a glomerulonephritis to transplant it to someone else.
Excellent. Thank you. Well, I think we're back close to the hour, and this has been a wonderful. We appreciate the fresh, young patient perspective from the pediatric nephrologist, and transitioning and what we can all do and learn from. And I'll ask you for any last comments, but we'll love to have you back. And hopefully in the near future when some of these new medications for IgA are being used in your patient population.
Thanks for having me. I think in closing, I'd like to say let's keep that discussion going between pediatric and adult practices. Think about the patients when we transition them and how difficult that process is and how much we can support that and help each other. And reach out to your pediatric nephrology colleagues. I know we do that all the time with our adult nephrology colleagues. And I was fortunate to have like you rotated in pediatric services. My whole PhD started because I had to do a 1 month rotation in adult nephrology services as well. And then I saw quite a few of our patients who we had transitioned over on dialysis with IgA nephropathy. And I'm like, wait, something is wrong here. Because if we're transitioning them over and we're like, bye, and they go over there, and in 5 years they're on dialysis, like something is not right. We need to know what's happening after we transition them because they didn't end up having good outcomes. And if we don't get that feedback as well, we're also going to think it's a benign disease, right? Because we don't see a lot of the failure before 18. Most of this happened in the adult world, but we don't get that feedback either. So I think the continuity of care is really important.
Well, thank you so much. And like I said, hopefully you'll have some new info for us soon as we can hopefully expand some of the use of some of these medications to our pediatric patients and have you back too with helping with more transitions of care for sure.
Thank you. I see one last question about role of budesonide. I think if we have access to budesonide, we will use it because it has less systemic adverse events. And if we know the target of the abnormal IgA is produced in the gut and budesonide has that direct gut-kidney access inhibition capacity, then it might be a better option for us. We still haven't been able to use it because we don't have access. And also the other thing, I tried to figure out what would be the treatment protocol if we did use budesonide, and there is no protocol established for budesonide in children. Tarpeo does not have like a lower dose other than the 8 and 16 milligrams. There are no liquid formulations. So those are the other challenges we need to think about. We can't dose milligram per kilogram if we only have 2 doses that cannot be cut or split, etc.
Well, thank you. And
Thanks.
thank you. Much praise in the chat again for an excellent talk. Thanks for sharing part of your Sunday with us. And we'll see
Thanks
everyone.
for having me. Take care. Bye bye.
Bye.